Hello, good evening. Can you see me? Can you hear me? Hello, everyone. Lovely to see you back again. Just before we start, I'd like to ask, is there anyone here who was not there yesterday? Can you please raise your hand? Stephen? Anyone else? Okay. So what we're gonna do, and Mohammed. Right. So just to summarize, yesterday we have done few scenarios and we talked briefly about the structure of the exam itself, the FRCS exam, and about our course. So what I will do today, I will go through few more scenarios. Again, whoever would like to volunteer to go through the scenarios with me, that would be great. And at the end, what we will do, I will repeat what we discussed yesterday about the exam and the course. I will keep that to the end. So whoever would like to stay, it will be exactly the same. They'll be more than welcome. However, if they prefer to log off so that I don't waste their time, you can go. Is that right? Yeah. Okay. Uh, anyone has got any question before we start? Mohammed, have you got a question, or did you raise your hand because he wasn't there, or do you want to volunteer to go for the first scenario?
Yes, I actually I wasn't there with you yesterday because I have busy work.
Not a problem at
It's
all.
pleasure to.
Not a problem at all. We'd expected that could not join yesterday. That's not a problem. But what we'll do, so this session is three parts. The first is test survivors with a few scenarios that we go through them. And then the
Yes.
other part is about the whole FRCS exam. And the third part is about the course. Okay. I'm going to start with the scenarios first. And whoever would like to stick around after, they're welcome to do so. If you did not hear that yesterday, then the last two section will be for you. Okay?
Okay.
Right, okay. So let's just make a start. It wouldn't be as long as today. I think it'll take about an hour and a half today. So we'll go through three or four more scenarios today. Anyone would like to volunteer to go to help me with the first scenario? Hussam?
Hello again.
Hi. Hi.
Hi.
It's nice to be here again. Right. So Hussam, got a case with you. You're seeing a 70-year-old gentleman with a lump in the neck. Okay. He has noted it a few months ago. Talk to me how, if that's a long clinical case. Okay. Talk to me what points in the history would like to go through and how would you assess that gentleman?
So first of all, I would introduce myself to the patient.
Mm.
Then I'm gonna start history taking, starting from the personal history like name, age, sex, what's the career of the patient. Second, I would go for analysis of the complaint itself, onset, course, duration, what increase, is there any exacerbating or relieving factor regarding the swelling itself. First, I'm gonna ask about the symptoms that's suggestive of thyrotoxicosis in form of loss of weight, being aggressive.
What are you talk to me in their language? What symptoms would you ask the patient about?
Loss of weight,
Okay.
sweating, tremors, um, uh, tremors,
Tremors, you
and
mean?
tremors, yeah, tremors.
Yeah.
Any change in the personality, like aggressive behavior in the last time.
Hmm.
Also sweating. Um, uh, yeah, that's mainly.
Okay.
Yeah.
Right. So he has got non-type 2 diabetes. He does not have any symptoms of thyrotoxicosis. The only thing that he mentions here that he was treated for lymphoma in the 1980s, about 30 or 40 years ago. He had radiotherapy.
Yeah. Okay. So radiotherapy for lymphoma. This can give me a clue that it could be papillary thyroid cancer or lymphoma. However, I would focus more in symptoms suggestive of malignancy in form of loss of weight, family history of malignancy. Yeah, that's it.
Okay.
Also, I'm going to ask about past medical history, past surgical history, any medication that the patient takes.
Talk to me, how would you carry out the clinical examination?
Okay. So I would start by doing general examination, how the patient looks ill, looks well, any apparent signs of jaundice, as a general look at the patient. Then I'm going to focus on the neck examination. I would take the permission from the patient. I would do the proper exposure from the chin to the sternal angle here. I would ask the patient to sit on the chair. I would stand or sit in front of the patient. I'm going to start by inspection to observe size, shape of the swelling itself. I'm going to ask the patient to take a sip of water and the protrusion of his tongue to differentiate, is it thyroid mass or thyroglossal cyst.
Sorry, how do you differentiate if it's thyroglossal cyst or thyroglossal mass again?
I would ask the patient to take
your iPad first. Sorry, I can't do that.
Sorry. Carry on.
No worries. I would ask the patient to take a sip of water. If the swelling move with the swallowing or deglutition, that's suggestive of thyroid mass.
Okay.
If the patient with a protrusion of his tongue, the swelling move, that means it could be or highly suggestive of thyroglossal cyst.
Okay.
Okay. So then I'm gonna ask the patient. I'm gonna ask the patient if there is any tenderness at the time. Then I'm gonna start the palpation. Okay. Then I would shift on the back of the patient. I would assess the mass consistency, edges, if it's pulsatile or not, if it's fixed to the underlying structure or muscles. I would observe any tenderness by keeping the eye contact with the patient. Then I would examine for any lymphadenopathy in submental, submandibular, deep cervical, occipital, pre and post auricular. Then I'm gonna do the auscultation for the swelling itself to rule out any PROE. That's it. Yeah. Regarding the exam. Then I would do the tremors, the reflexes, and
how do you check if this lump is causing compression symptoms?
This is this should be from the history itself first.
Okay.
To ask the patient, and to
is
assess.
there anything that can check with clinical examination?
Yeah. I would put my finger to assess if there is in front of sternocleidomastoid muscle. This can suggest of compression of the trachea itself. Also, I would do the percussion to see if there is retrosternal extension of the swelling itself.
Okay. So, and what investigations would you do to this gentleman?
So I would start by full sets of blood, including full blood count, to look for any signs of anemia, as to rule out any thyrotoxic manifestation. I would ask for urea and electrolytes, coagulation profile. I would order thyroid function test. I would order tumor marker in form of thyroglobulin.
So if I'm telling you that the T4, T3, TSH are all within normal limits, would that be assuring to you, or how would you interpret that?
No, at all. It will not be assuring for me. This is could be hypothyroidism after our hypothyroidism stage after hyperthyroidism. This is the first. The second could be malignancy.
But if it's hypothyroidism after hyperthyroidism, would you expect TSH to be normal?
To be high, not normal.
So if they're all normal, both normal, TSH and T3 and T4,
yeah,
how would you interpret these results?
There's lots of differential diagnoses still, like
Right.
malignancy, lymphoma, Hashimoto's thyroid, lots of causes still. We need to rule out.
Okay. So what's the next step of investigation to rule that out?
I would start by NIC ultrasound to assess the thyroid gland itself for any masses.
So if I'm telling you that the ultrasound is reported as U3 lump in the left thyroid lobe, what does U3 mean?
This is undetermined lesion.
Okay.
Also, we need, this is follicular lesion, let's say. We need histopathology
Okay.
to differentiate between follicular
How will you obtain the histopathology?
hemathyroidectomy.
Sorry. So histopathology to start with. Will you just go with hemothyroidectomy
No,
after the
sir, no,
ultrasound?
I would start by FNA, fine needle aspiration cytology.
Do you know what's the classification of the results of the FNAC?
Yeah, it's 5 grades.
Okay.
The first grade is benign. The second grade, from 0. This is inadequate. We need to repeat. 1 benign. 2 still benign, but we need follow up after 6 months. 3 undetermined lesion, either to repeat or to order or to take biopsy in form of fine needle aspiration cytology. 4th grade is suspicious of malignancy. 5 malignancy.
What's the name of that classification? Do you know?
The name, okay. The American system, it's Bethesda, and
Bethesda.
the British, Bethesda. The British one, it's called I forget the name.
So according to the FNAC, it came as Thigh 3.
Thigh 3.
What does that mean, and what are the subtypes of Thigh 3?
So it's could be follicular lesion.
No, there are 2 subtypes of Thigh 3.
2 types, yeah. The
Yes.
follicular lesion. The other one, I think, atypical hyperplasia.
Yeah. So it could be either Thigh 3F or Thigh 3A.
Yeah, atypical hyperplasia and follicular lesion. Yeah, exactly. Yeah.
Okay. It came back as Thigh 3F. What does that mean?
That means we have follicular lesion.
Okay.
We cannot differentiate, is it adenoma or carcinoma? We need a tissue biopsy, which means diagnostic hemothyroidectomy.
Okay. Right. Can you consent that patient for the operation, please?
Yeah. Okay. So I'm Dr. Hussam, the leading doctor for your case. You came to me by complaining of swelling in your neck. After doing the examination and the appropriate investigation, we found a lesion inside the organ here. It's called thyroid gland, and the biopsy revealed there is some tissue. We are not sure about the nature of this tissue. To be 100% accurate about the nature of this tissue, we need to do an operation. It's called diagnostic hemothyroidectomy. We were gonna take a part of this gland. After the result after discussing the result with the doctor of histopathology doctor, we're gonna decide if we gonna complete the operation and removing all the gland in the case of presence of bad cells or cancer, and that, like any other operation, it will be under general anesthesia, and there is some risk that it may happen. And mentioning of those risks does not mean it will happen, but still there's a risk. We're gonna start by bleeding inside the operation itself. In some rare cases, that procedure will lead to injury to the surrounding structure there, like vein, arteries, or nerves. As I told you, mentioning of those risks does not mean it will happen, but in rare cases that may happen, which include injury to the nerves, that your voice will be affected, or and in cases of we remove all the gland, you need to take something is called thyroxine to compensate the hormones secreted by this gland.
Okay. So let me just ask a few questions, Sam, here. if you do the hemothyroidectomy and came back at thyroid cancer, follicular cancer, what would be the next step of management?
So first of all, in cases of follicular cancer, the procedure of choice would be total thyroidectomy with central neck dissection.
Is it dissection or radiotherapy?
Neck dissection, not radiotherapy.
Okay.
And also
Could you-
there is a history. Also there is a history. This patient had a history of radiotherapy before.
Excellent, excellent.
Yeah.
That's when it comes here helpful in the history. I did not give you that information for any reason. There is an alternative. If you don't want to do neck dissection, you can give radiotherapy. However, as a general rule of thumb, we know you cannot give radiotherapy to the same site twice.
But it's a dose, yeah.
Okay.
It's a dose for all the life, yeah.
Yeah, so that's why it's here you have to go with neck dissection. Do you know what are the indications of radioactive iodine?
For thyroid cancer.
Yeah.
So in cases that there is lymphatic spread, we need to give
Mhm.
radiotherapy. Is the first thing. The other indication, maybe in some cases of thyrotoxic manifestation, eye manifestation or something.
That's not related to the cancer scenario. Yes, that could be done as Graves' disease or thyrotoxicosis, but I'm talking as an adjuvant treatment after surgery.
Yeah, it
Did
could
you
be
give
in
it
cases also in cases of palliative treatment. In case of bone mets, we might use radiotherapy.
Yeah, so you give it in T4, N1, or M1 cancers. Do you know any guidelines
Regarding?
regarding the treatment of thyroid cancer?
No.
Okay, there are ESMO guidelines, European Society of Medical Oncology guidelines, and there are NICE guidelines. Well done, Hassan. Very good, very good. No, so this is a common, actually, long clinical case in the FRCS. Okay, it's quite easy. We all have done thyroid examination before, and when it comes to this unfamiliar territory like vascular endocrine or transplant, for general trainees, I'm talking, it could be quite easy and quite difficult, because if you know it, you don't need to go in depth of the details. You just need to know ST4 level knowledge. So that actually, when I've gone through the questions of radioactive iodine and the ESMO guidelines, that was really stretching the limits to give you the full mark. That's how it goes. But what you need to know is really ST4 level knowledge. The issue that if you do not have that ST4 level knowledge, you will lose the whole mark. You will just fail. So it's all or none. That's why it's one of these branches that it's very helpful to know what exactly you need to know. Okay, you don't need to go in depth of everything. The only thing that I would say that you should have done, Sam, is to discuss in the endocrine MDT.
Yeah.
Right, that's a cancer case. Okay, you need to discuss it with the oncologist. You need to discuss it with the endocrine MDT. Okay, hemithyroidectomy. Also, that could be a general surgery operation. Thyroid cancer and dissection, that's an endocrine surgery, endocrine surgeon. Okay, so at some point you have to discuss in the community. And the other thing, I'm not sure if I missed that, please correct me. When you consent the patient, have you consulted him about hypocalcemia?
No.
Right, okay. And the effects of parathyroid. And have you discussed with the patient any effects on recurrent laryngeal nerve injury?
Yeah, I discussed that.
Okay. So it's just hypocalcemia related to the parathyroid, the thing that you missed.
Parathyroid gland.
Okay. Yes.
Yeah,
okay. Well done. Thanks, Hassan. Anyone has got any question about this scenario? Okay. Hopefully that would give you a glimpse how it works. Anyone would like to go for the next scenario? Anyone keen to try the luck? I wouldn't be hard. Sapien, are you around? Would you go with me for the next one, or would you rather not?
No, I can do it. That's fine.
That's great. Okay. Sapien, you are in the general surgery clinic. Okay. You have referred a patient from your rheumatology colleague who's got ITP for consideration of a splenectomy.
Yep.
Okay. So, few questions first. What is ITP?
Idiopathic thrombocytopenia.
Okay. How does it present?
Usually presents with bleeding, either sort of bleeding disorders, splenomegaly as a clinical finding, sometimes splenic rupture, rare.
Okay. What are the indications of splenectomy and ITP? So, do they always go with the splenectomy as a first option?
No, you can try medical therapy. I think in the form of, I think it's rituximab.
Okay, great. Yes.
Usually give.
Well, rituximab is the second line. The first line is what? Steroids.
Okay.
Steroids is the first line, and then the second line, as you said. What is the mechanism of action of rituximab?
Sorry?
What's the mechanism of action of rituximab?
I think it's an anti-CD20 antibody, I think, isn't it?
Let's just give you the cheat sheet, everyone. Anything ending with MAB is a monoclonal antibody. Anything ending with MAB, even pertuzumab, trastuzumab, which is the Herceptin. Anything ending with MAB is a it stands for monoclonal antibody. Okay. So yeah. So if there is a failure of medical treatment, you would consider splenectomy. What are the indications of splenectomy in general, not for this patient specifically?
General indications for splenectomy, so could be various hematological malignancies.
What's the commonest?
Trauma.
Trauma, of course. Yes, this is the commonest indication of splenectomy.
Trauma. Second probably common etiology you're looking at is sort of distal pancreatic tumors undergoing surgical resection, hematological malignancies. Trying to think. Nope.
As anything, which is could be traumatic or non-traumatic indications. So I mentioned the trauma, the first one, the non-traumatic and neoplastic, as you said, hematological. The other thing is infection, abscess or hydatid cyst.
Yeah.
Okay. So let's go back to our patient. We're not hematologists, we're surgeons, right? You're seeing that patient in the general surgery clinic. How would you prepare that patient for the operation? What would you like to do?
So it would depend on what's the size of the spleen, really. If it's quite a giant spleen, then I'll be consenting for an open operation. If it's not so sizable, then potentially can consider laparoscopic, but I'd say there's a high risk of conversion to open, particularly if you're consented for ITP and things, various tumors. It's going to be quite a large spleen. So I'm going to walk them through the consent process, which essentially says be a bin-line laparotomy, most likely if it's a large spleen, with a view to removing the spleen, which has significant risks associated with it, which includes bleeding, damage to surrounding visceral structures, pancreatic fistula. The other is recurrence of ITP. There's a reasonable amount of risk which may require further medical therapy. After that, general risk of anesthetics, which comes with the risk of getting clots in your legs, lungs, heart attack, and things like that. And also consent for blood transfusion.
So, what blood tests will you like to do for this patient before the operation?
Full blood count, use LFTs. Essentially looking at.
Remember that patient has got ITP. So you're mostly concerned about the platelet count, isn't it?
I'm going to look at platelet count and also do a platelet
What's
film.
your threshold to operate?
For platelets?
Threshold,
about
yes.
50.
Okay, so you've done the full blood count, and the platelet count is 20,000.
Yeah. So I'm going to have, so if the platelet count is 20,000, I'm going to have to discuss this with a hematologist to see how we can best correct this. This could be in the form of trying steroids in the first instance, if there's time for that. Otherwise, consider platelet transfusion and discuss the time frame. Sorry?
Will it work?
Platelet transfusion?
Yeah. Why does he have low platelet counts?
Because platelets are being sequestrated in the spleen and being
Right.
destroyed.
So would it help if you transfuse him more platelets?
It's unlikely to help. 'Cause
Okay. What will help?
Vasopressin.
Right. Okay. Anything else?
Steroids.
And
Don't know.
okay. Right. Okay. Right. We'll answer that at the end. What are the specific problems that you worry about with the splenectomy
Specific
or after
problems.
splenectomy? Yeah.
So post-splenectomy sepsis.
Okay. Why does that occur?
It occurs because essentially encapsulated bacteria aren't being protected.
Which ones?
After.
Can you name few?
Yeah.
Like what?
So Haemophilus influenzae would be one of them.
Yeah. Meningococcus.
Meningococcus.
Yeah. Okay. Right. How do you prevent that from happening, and what would be the post-operative prevention strategy?
So preoperatively, you'd consider vaccinating these patients 2 weeks prior to the operation.
Okay.
If they haven't been vaccinated, you would want to vaccinate them at least 2 weeks afterwards. Consider prophylactic antibiotics for 2 years in general population. I think there's a massive amount of evidence for lifelong antibiotic prophylaxis anymore. Those are the sort of main things you would want to do. Otherwise, like I said, pancreatic fistula would be a risk. If that happens, then that could cause significant sepsis and various complications afterwards.
Since you're a great candidate, so then let's up our game with asking a few questions more. Okay, so immediately post-operative, you've done the splenectomy, you've got a drain, you're doing the ward round after a week, and your registrar is telling you there is a very high drain output.
Yeah.
How would you investigate that issue, and what's the possible cause?
Yep. So I'm going to have a look at the drain content to see what it looks like, whether it looks like bowel content, or whether it looks like pancreatic, or whether it's an infectious sort of content. Send it for drain fluid amylase. Given pancreatic fistulas are quite common after splenectomy.
Okay, so drain amylase is very high.
Yeah. So we know that there's a pancreatic fistula.
How would you manage
it? There's various ways in which you can manage it. One is you want to make sure that you send it off for some culture. Two, when we're saying high, how high are we talking about?
We're talking about higher than 10,000. No,
the volume per day.
Sorry, the volume there. They're talking about 500 mils a day.
Okay, that's quite a significant volume. So what I probably want to do is consider starting octreotide. Make sure the patient is fluid resuscitated to replace any losses in it and correct any electrolytes. The other is, given that we've started octreotide and there's ongoing pancreatic fistula, I'd want to make this patient nil by mouth. Essentially, they could have fluids and consider TPN until that settles.
How long would you expect that to take to settle?
I would hope it sort of starts to settle over the next few days in terms of volumes coming down and things. If it doesn't settle, then I'm going to have to think of alternative strategies, which would potentially consider doing an ERCP or a pancreatic stent.
Okay, that's great. That's fine. We have sorted that patient. He's settled now, has gone home. You're seeing him as a follow-up after the lovely operation that he had done 6 months in the clinic. He's done a set of bloods, and you noted that there is a persistent low platelet even after splenectomy. What are the possible causes?
Possible causes are there's residual spleen left in the patient. So you're essentially looking at things like spenenculi and things that could potentially have been missed during the initial operation.
Okay. What else?
I think you're looking at disease recurrence. And very rarely you're looking at other causes. So also you have to take into context of whether you'd want to do a repeat sort of your blood films and maybe marrow biopsy at this stage, but you'd want to discuss this with the hematologist at the hematology MDT.
Okay, All right. What advice would you give to the patient as long term to prevent overwhelming pancreatic sepsis from happening?
Pancreatic sepsis, sorry.
So it's OPSI, to prevent OPSI, you know, overwhelming post-splenectomy infection, sorry.
So essentially, the kind of things I'll say, to make sure they get their flu vaccines and various influenza vaccines and things on a regular basis and annually. I would want to make sure that if they have a emergency supply of antibiotics available with them, and so if there's any subtle signs of infection, then they start taking that and seek help immediately.
Okay, thank you. Thanks, Etienne. Right. Unfortunately, that's a very common scenario. I think that was one of my scenarios in my exam. This happened to me. So in the general surgery Vivas, you will find some annoying topics, things like splenectomy. What are the functions of the spleen? Things like, of course, interior hepatic circulation of the bilirubin. Someone has been asked about actinomycosis, unfortunately, and amyloidosis. I'm not asking you to go and all read all that. If you know it, that's great. But the issue here, you do not want in the exam to get this question get into your nerves. Even if you don't know the answer, that's fine. But at least you can cope in for the rest of the stations. Well done, Satin. That was great. Few things. One of the very critical bits that they would like to know in the exam, especially, is about how to treat low platelets during or around splenectomy. Especially if it's ITP, you cannot transfuse platelets because it will be just breaking down by the spleen itself. You can give IVIG, okay, intravenous immunoglobulin, especially in ITP because it's autoimmune. The other thing which is very critical, you get platelets ready, standby to infuse in case there is intraoperative hemorrhage. If you're going to infuse platelets intraoperatively, at which stage of the operation would you infuse them, Satin, do you think?
I think probably when the patient is actively bleeding and probably towards the end of the operation, when once you've clamped off the artery to the
exactly, that's the key thing. That's what they would like to hear. So you do not transfuse the platelets unless you clamp the splenic artery, because otherwise it's going straight to the spleen to be broken down again. Okay. So yeah, these are the few things. And with persistent low platelets after, you have to double check that there is no intraoperative splenic fragmentation. Okay, that could have caused any overgrowth of spleniules anywhere. And you need to know that 8 to 10%, even after RTP, a successful splenectomy would have persistent low platelet count anyway. Okay, right. Any question? Thank you. Thank you very much, Stacy.
Thank you.
Any questions about that scenario? Okay. Right. I would give one more scenario since there is lack of enthusiasm. Okay. And then I will just go again about my talk that I've gone through yesterday. So if you'd like to stick around to hear it, that you're more than welcome. But if you'd like to go, you're free to go. I know it's late sometime. Guy, do you want to go for the next one, or have you got a question?
Yes, I would like to go for the next one.
Okay, great. Right. So, okay, you are in the breast clinic. You're seeing a 57-year-old gentleman presenting with left breast lump. Okay, I will show you a photo now. You tell me what you can see here. Let me know when you can see my photo. Can you see it?
Yes, I can see this.
What can you see here?
It shows the left-sided upper chest of a male gentleman. There is distortion of the nipple areola complex with a puckering of the skin. I do not see any ulceration, any obvious nipple discharge, and changes in the skin such as erythema, body orange appearance. But what is obvious is a nipple which is distorted and there's a oblique puckering of the skin. Yeah. As for the axilla, I do not appreciate any obvious swelling.
What do you think is going on here?
I think probably there's an underlying mass, which is most likely malignant and causes the retraction of the skin and destroying the nipple.
Okay. What do you think is the cause of that mass? Do you think it's benign or malignant?
It's most likely malignant. So I'll be
Okay.
suspicious of a malignant breast cancer in a male.
How common is breast cancer in males?
It's actually quite uncommon. The prevalence is higher in patients with family history of BRCA2, and otherwise the exact incidence, I'm not sure.
Okay. It's about 1 in 10,000.
Okay.
1 in 10,000 male. What is the incidence of breast cancer in females?
The incidence in female is much higher. It is at the range of about 1 in 8 or 1 in 10.
1 in 12.
Oh, sorry, 1 in
So it's
12.
about 12%. Yeah, it's about 12. It's the commonest cancer in females, is a breast cancer. So compared to the male is a 1 in 10,000, isn't it? What are the risk factors for breast cancer in males? You mentioned one of them is family history with BRCA mutation. What else?
It could be due to previous radiotherapy to the chest wall. The radiotherapy may be given in the younger days, for example, for any sarcoma. Other risk factor could be hormonal usage,
Like what?
like steroid hormonal usage like estrogen or estrogen hormone.
Why would a male use a estrogen? In which circumstances would a male use estrogen?
Steroid.
Anabolic steroid. So do you
Anabolic.
think that anabolic steroid can increase the risk of breast cancer in male?
Probably yes.
Okay. So we know that increased estrogen can cause gynecomastia in males. The question is, does gynecomastia increase the risk of breast cancer? Or does increased estrogen increase the risk of both gynecomastia and breast cancer?
Yeah, I think increase in estrogen causes both increased risk of gynecomastia and breast cancer.
Okay. Talk to me about BRCA gene mutation in men. Okay.
Okay.
What are the types of BRCA gene mutations? And which one is more common in men?
BRCA, there's a BRCA type 1 and BRCA2.
Okay.
BRCA2, breast cancer in men is more often due to BRCA2 mutation.
Okay.
It is inherited as a autosomal dominant fashion. Apart from the risk of breast cancer, they are also at increased risk of other cancers such as pancreatic cancers, small bowel cancers, and also prostatic cancer.
Sorry, small bowel cancer, you said? Prostatic cancer. What type of small bowel cancer is associated with BRCA mutation?
I think it is. I'm not sure. Maybe adenocarcinoma. Okay.
Okay, right. So, what about females? What does BRCA gene mutation, which cancers do BRCA gene mutation cause in females?
So for female that high risk for breast cancer and also ovarian cancer. Yeah. So
Do you know what's the incidence of breast cancer in females with BRCA1 mutation?
so the risk of breast cancer in patients with BRCA1 is higher. It can go up to 70 to 80%. As for BRCA2, the risk is slightly lower, probably up to 60 to 70%.
Okay, right. Let's go back to our patient. Nice patient of ours. Okay, so he is a gentleman, 65-year-old. His sister had BRCA cancer. Okay, and he's got BRCA mutation as well. And you see him, you feel that is hard eccentric maths. Okay, what would be the next step of management?
Okay, I will still proceed with the algorithm of taking a history, a triple assessment consisting of the clinical history taking. I would like to focus on the onset, duration, any symptoms of pain, any lumps elsewhere, and also the risk factor for breast cancer, which is the sister's family history and BRCA. I would like to know the patient's comorbidities. Is the patient on any medical medication or has any past legal history? I'll then move on to assess the mass. There's a hard eccentric mass. I would like to know whether it is adhered to the underlying chest wall, whether there's any, how is the contralateral breast, whether any suspicious lump, and also check for the regional lymph node, axillary, as well as the supraclavicular and cervical. So one thing I missed is I would like to ask about symptoms of metastasis, such as back pain, bony pain, difficulty in breathing, or pathway for any hepatomegaly. I'll move on to the imaging. I will arrange for a mammogram.
Mammogram for one breast or for both breasts?
For both breasts.
Okay.
And an ultrasound of the breast and axilla.
Excellent.
Then arrange for histopathological examination by performing a core biopsy.
Okay, so we'll go to that. So the core biopsy is done and it's coming back as breast cancer. Let me ask a few questions. What is the commonest type of breast cancer in male? Is it estrogen sensitive or resistant? ER positive or ER negative? What do you think?
It is for BRCA2. It is
No, for that, yeah, or for in general.
in general.
Or for BRCA2.
For in general, I think it is sensitive, ER positive.
For men, ER positive or ER negative?
Sorry, negative.
Negative.
Actually, I'm not sure.
Okay, that's fine. That's the right answer. What are the histological types of breast cancer?
Okay, it is it is the it
There are
can
two
be,
main types.
yeah, there are two main
Be
types.
either-
I can't recall the name, but I know for the main types, it is further subdivided into a few types, such as medullary or sorry, I have left
It's
breast.
okay. So the main types, the main histological types are ductal and lobular cancers. There are
Okay.
many subtypes which are medullary cancer, tubular cancer, cribriform, all that. These are, we go through these with details with breast trainees, but you're not breast trainees, so you don't know that. But you need to know, is it ductal or lobular? What do you think the commonest type of breast cancer in men? Is it ductal or lobular?
Lobular.
If you don't know those, okay, right.
Okay.
It's ductal. It's 99% ductal. Lobular breast cancer in men are case reports.
Okay.
Okay, it's 99% is ductal. Are there any other receptors that you would like to know from the histopathology that would guide your treatment?
Okay. I would like to know the degree of differentiation, the grading of the
Okay.
tumor. Is there any lymphovascular invasion?
Okay.
Also, like to know the size of the tumor because that will affect my T staging.
Excellent.
And I would like to know whether there's any lymph node involvement. Yeah, so I can stage according to TNM staging.
So have you heard about Herceptin or
Yes.
HER2 receptors?
Yes. Sorry.
What is HER2 receptor?
HER2 receptor is a human epidermal receptor.
Okay.
So if it is a prognostic indicator, a prognostic factor.
Bad or good prognostic indication? So if the cancer is HER2 positive, is that good or bad?
Actually, it's a poor prognostic factor.
Yes, it is. It is
Yeah.
poor prognostic. I agree with you. Okay, so the cancer we have is 6 centimeter, grade 3, invasive ductal cancer, which is estrogen sensitive, ER positive, HER2 positive. Okay, and you could see that there are 4 lymph nodes in the axilla that are positive. What will be the management for this patient?
Okay, so I'll bring this case to a MBT discussion. So this is a T3, and sorry, how many lymph nodes again?
4.
4. Okay, T3 and 2, with no distant metastasis, and mastectomy.
How do you know?
Sorry, I will arrange for a CT scan for complete
What are the
staging.
indications of staging CT? Do we do staging for every breast cancer?
Um,
In the UK, at least. Because
okay.
that's different in countries. That's one of the things when you need to know, they assess whether you know how breast is done in the UK or not. What are the indications? Do you know or not? If you don't know, that's fine.
I'm not sure.
Okay, that's fine. Let's move to something else. So you bring that to the MDT. So we are assuming that's T3N2 M0. Okay, we have done staging CT and that's fine, and that's clear. And you have seen the cancer there. Do you think, let me show you the photo again. Do you still think that is T3N2? Let's go again through that photo. Do you think that's T3 cancer?
Okay, so there is a skin involvement here. So
Yes.
it's T4B.
It is T4. Regardless of the size, it will be T4 cancer because there is a skin ulceration, isn't it?
Yeah, yes.
Yes. So that's T4N2 cancer. What would be the management guide?
He will require an adjuvant radiotherapy to the chest wall. And also he also requires adjuvant chemotherapy and adjuvant hormonal therapy since he's RPR and Herceptin positive.
Which surgery do you think you'll have?
He will have a mastectomy and axillary dissection.
Maxillary mastectomy and axillary. We don't call it axillary dissection here. We call it axillary node clearance.
Okay.
Rather than axillary dissection. It's okay. That's fine. No, thank you very much. Thanks.
Okay,
I know that was not the easy scenario, but unfortunately, this is a very, very common short clinical case for general trainees in the exam. They love male breast cancer. Few things to check. Okay, male breast cancer is extremely rare. As I said, it's 1 in 10,000. Okay, there are 2 main risk factors. That's not one of the killer mistakes in the exam to say it's due to hormonal imbalance. No. Hormonal imbalance or increased estrogen can cause gynecomastia, does not cause male breast cancer. The 2 main risk factors for breast cancer are genetic mutation, BRCA mutation, and Klinefelter syndrome. Okay. To the extent that any male breast cancer who is not known to have BRCA mutation, we have to test him for BRCA mutation.
Okay.
Okay. Right. What cancers do they get with BRCA mutation? That depends. Is it BRCA1 or BRCA2, or depends is it male or female? Okay, and BRCA mutation and P53 mutation, Leaf-Romania syndrome, and CDH1 mutation, these are not even breast. This is general surgery. These are very common short Viva questions. Okay. In the exam. So with BRCA mutation in females, as you said, they get breast cancer, ovarian cancer. Okay, that's what they get in females. They don't get bowel cancer. No.
Okay.
Right? Because the moment you say that in the exam, right, I will not tell you that you're wrong. I will tell you, I'll ask you, do you know which genetic mutation can cause both breast cancer and bowel cancer? So you got yourself another question.
Okay.
Okay. This is exactly the flow of the question in the Viva exam. Let's go back then. So in male, BRCA mutation can cause breast cancer, prostate cancer, and pancreatic cancer. Okay. So this is the risk factors. You've done the investigation very well, very good. Thanks for mentioning triple assessment. 2 keywords you have to say in any breast case in the exam: triple assessment, breast MDT. You have to say both. Okay. So we've done triple assessment. We'll do imaging, which is mammogram and ultrasound. Believe it or not, some general trainees, they don't know that we can do mammogram for men. We definitely can. We definitely can. So you have a mammogram, we'll have an ultrasound. We'll go through that in the course, but the main question we ask ourselves as breast surgeons and for general, the main decision you need to make, is it surgery first or is it neoadjuvant chemotherapy? There is no third option. So it's either surgery followed by chemotherapy or not, or no, started by neoadjuvant chemotherapy. Without going into lots of detail, this is locally advanced cancer, so you have to start with neoadjuvant chemotherapy. Okay? Few facts about male breast cancer, again, very common exam questions. The 85% are estrogen positive, ER positive. Okay? And 99% are ductal cancers. Men don't have lobules. Anatomically, they don't have lobules. So if you find a lobular breast cancer in a male, that's a case report. I've done one. And while I'm doing it, I found there are actually 6 or 7 cases of lobular breast cancer in men. So that's why to say the commonest one is lobular, this is actually a fatal mistake. It's almost always ductal. I'm not judging you, just discussing that now. Okay, so that's about the male breast cancer. So that man will have neoadjuvant chemotherapy, will have surgery afterwards, and it's important to know that in men we do not do breast conservation. There is no point doing breast conservation. It's always mastectomy, and because the lymph nodes are involved, it is axillary node clearance. Indication of staging for breast cancer, you need to know that it's T3 or above, N2 or above. Okay, or if there are clinical symptoms of metastasis like back pain or hemoptysis, anything like that. Otherwise, there is no indication. Any cancer which is not T3 or above or N2 or above, we do not do staging at all.
Okay.
Okay, that's one of the things. But yeah, thank you. Thanks, mate. Anyone has got any question about that? You're welcome. Thank you.
I would like to know, with that performance, will it be a pass or fail?
Will it be a pass or fail with your performance? Do you really want to know?
Yes.
It will be a borderline pass. It will be a borderline pass.
Okay, thank you.
Depends on the examiner. Okay. You have said some killer mistakes.
Yes.
Like it's lobular breast cancer. You did not know what are the indications of staging. You mentioned that BRCA mutation can cause bowel cancer. All these are not true. Okay, there are a few advanced things that you did not know, but you got the core things right. So it's not something that I would like you to risk in the exam. Okay, depends on the examiner. If the examiner is lenient, they might give you a very low pass. It's like 5. Okay, but if an examiner fail you for that, no one can blame you.
Okay, thank you.
The thing about the breast is, you see all the things that I told you. If you'd like to study male breast cancer for the exam, it's literally half a page. It's literally half a page. Once you know it, once you read it, you know it. And if you know it, you could easily get the full mark in this station in the exam.
Okay.
If you don't know it, you will fail.
Okay.
This is why I think breast is one of the important things in the exam, breast especially for general trainees, because once you know it, you guaranteed yourself passing with flying colors.
Okay. Thank you. Thank you.
You're welcome. No, you're welcome. Okay. Thanks. Anyone who's got any question about this scenario? Okay. Right. Probably you're not very ready now to go for more scenarios unless you wish to. So what I will do now, I will go through my previous presentation about the exam itself and about the course. Okay, it will not be so much different from what we discussed yesterday. If you'd like to stick around to hear it all again, you are more than welcome. However, if you want to leave, you're very welcome to do so as well. There are no hard feelings. I'll just go through it very quickly. Can you see my screen? Yeah, great. Okay, right. This was the session agenda. Some Viva essential scenario that we have gone through. So the two sections remaining is section 2 exam, what is it and how is it done and what do you expect, and then the course itself that we offer, what do we offer and how to get the best of it. Okay, so the FRCS Section 2 Viva, the GCIE, which is not the international one. With if there are any international candidates, Mani will post something separately about what the other variations about it, but I'm talking mainly about the UK one. Okay, there are two parts for the exam. The first one is the clinical, the other one is the Viva. They are done on 2 separate days. They do not have to go in a certain pattern. It doesn't have to be Viva in the first day and the clinical in the second. It could be either order. Okay, clinical, it would be 2 examiners on each table. There are 2 sets. The first one is general surgery, the other one is special interest. Okay, general surgery would involve anything from colorectal, upper GI, breast, endocrine, vascular, and that would be 1 long case and 2 short cases. Every short case 20 minutes. The long case is 20 minutes, and that would sorry, the 2 short cases, everyone's 10 minutes. The 1 long case 20 minutes, and that would, half of it would be history and clinical examination, and then they will discuss it with it, and it has to end with consenting the patient or breaking the bad news to talking to the patient itself. Same for the special interest, but that would be according to your chosen subspecialty. The other part is the Viva or the oral. That would be 6 scenarios, 6 stations. Everyone is 5 minutes. That would be 30 minutes each. So the first table would be emergency surgery, trauma, and critical care. The second one would be general surgery principles, then special interest surgery, and basic principles. And that's basic principles, and then the academic foundations. It's no secret that the marks that you get for clinical is not the same for Viva. So it's not 50-50. Clinical has actually more marks compared to Viva. Okay. And if you go back and see here, you see that 1 long case have got marks exactly the same as 2 or 3 short cases. That's why I always say the long clinical one is the most important station in the whole exam. If you do well in that one, then you can make it up if you don't do as great in Viva in one of the other 5 sessions. But if you do very badly in the long clinical case, it would be very hard to make it up for that. When you go for the exam, okay, when you're sitting in front of the examiner, what are you expected? You're expected to perform at the level of the first day consultant, day 1 consultant. 50% they assess your knowledge. Do you know that information or not? But 50% is assessing other things. Things like how you behave, what's your body language like, what's your tone, are you convincing as someone who can act as a consultant? Okay, how do you perform under stress? And that's one of the things in the exam. The exam is designed in a way to put you especially under stress to see how you perform. Think of it like this. You are in theater coffee team, in theater coffee room, discussing with a junior registrar about a condition or an operation. So it is respect. You are telling him what you need to do. It's something like this. Okay. You are a senior surgeon, so do not say I will discuss it with my senior. You are the senior. Okay. It's two-way conversation, not like MRCS. They would like to know how you think, how you process, how to react to the scenario. That's why there are no set of questions. You always get a question according to the flow of your answers. And that's something I said yesterday. One of the common mistakes that when you ask your previous colleagues about their feedbacks, they will tell you, oh, I had that station and the questions are asked about 1, 2, 3, 4, 5, these questions. These questions are dynamic and not static. Your colleague has been asked these questions based on his answers. So, and that's what happens when they tell you that I had these difficult questions. They tell you what difficult question they had, but they wouldn't tell you what were his answers that led to these questions. Remember, this is not single best answer. Okay, there is not MCQ. There is no single right answer. You do not have to be backed in the corner to answer, is it right or wrong? And the example I always give, if they ask you, oh, this is a patient with breast cancer, and you offered her wide local excision, she wants to have mastectomy, what do you think? You do not say, yes, I will do mastectomy for her because that was what she wanted, or no, I think wide local is better, you do wide local. You don't have to choose a single answer. Remember, that's survival. What you're expected to do is to show understanding of the rationale and say, well, it's a patient wishes, but what I will do, I think wide local might be in her best interest. I will explain to the patient there is no difference in outcomes when it comes to survival, overall survival, and local survival. There might be slightly higher risk of having further operations if it's got positive margin, and she'll need radiotherapy. But if she prefers to, however, wide local excision has got better cosmetic outcome. You did not say which one is better. Okay, you have explained your rationale, and mostly that is the right answer, even if you did not choose one other than the other one. Okay, you will have actors. It wasn't the case during COVID. During the COVID, there were no patients or actors. Okay, but now you can have real patients, especially with patients that they have got clinical findings, things like lumps and bumps and hernias. Okay, and they have actors, role players. Role players are actually they are recruited from professional agencies. They are given certain scenario about like you are a female, you had a breast lump that was 6 weeks ago, and you have noted it stopped being full. It has progressed there, and they give them things to act on based on what you do. So if the candidate try to ask you for that information, yes, these are the information they can give freely. Do not give that information freely unless you're asked. And once they start telling you that you've got cancer, you have to panic, things like that. Okay. Questions are built up from easy to more difficulty, and that's something very important. We'll go through this shortly when it comes to the anatomy of the question. The first question is a broad question meant to build up from the easy, general, generic, and goes build up there till you go to the niche questions, as we discussed when it comes to the splenectomy yesterday and when we discussed with the thyroid. You start with a presentation rather than a condition. And remember something. Now you know that there is a Viva situation, for example, about thyroid cancer. But in the exam, you do not know what is that about. If I tell you that the scenario is about someone who's got epigastric pain, that could be perforated GE, that could be cholangitis, that could be AAA, okay? You do not know. So it has to start with you've got someone who's coming with abdominal pain, how would you assess? So you have to be very careful. You have to show that you've got a scheme. You have to show that you are safe. You have got situational awareness. We'll go through this shortly. Common things are common, and that's very important. If I ask you for a differential, don't go for the very rare to start with. That will provoke the examiner, okay? Common things are common. If I tell you the patient's got I've got epigastric pain. Yes, you have to mention that could be gastritis, that could be PFTE, if it's surgical emergency, AAA. Do not start by saying, oh, that could be TB of the spine. Could that present with abdominal pain? Yes. Is that common? Absolutely not. So even if you have to say that, do not start with that. Okay? Evidence is important, but not so important, and that's one of the common misconceptions. Trials and guidelines, they're important to give you the full mark, but you will never fail not for knowing the trials. Okay, you will only get asked this once you have built up through the scenario and you came to the end. But do not just waste time, especially if you're something like breast. We've got loads of trials that we have to go for breast. Breast are like half scientists, half genetics, plastic surgeons. They have to be a bit of everything. No one ever failed because they did not know the trial. Yes, you will not get the full mark, but you will not fail to get that. You have to make sure that your responses are structured and organized. When we go through the feedbacks, and that's something they have introduced recently, if this is not your first attempt and you have attempted before and you did not pass for a reason, you can ask the GCIE for feedback. And if you go there, you will find what the examiner have written. And one of the common reasons for failure was actually lack of organization and lack of higher order thinking. Okay, we have experienced that today. Feel free to say, I don't know. You say wrong answer, the examiner will not tell you that, oh, you're wrong, correct yourself. They will just humor you and say, oh, really, you think that? How come is that? What is the commonest type of breast cancer in males? Is it Dr. Lobular? Lobular, okay, what is the ratio, what is the risk of having lobular breast cancer? How would you do that differently? And you will start doing things and things and things. A scenario that I always say is for breast trainees, they had a scenario for breast cancer and pregnancy. And the question was, she's 11 weeks pregnant, she's got breast cancer, how would you do? This is tricky situations, just to give you the context, because in breast cancer and pregnancy, it's always neoadjuvant chemotherapy. We can do surgery, we cannot give radiotherapy. So if it's second trimester, neoadjuvant chemotherapy, third trimester, if it's early neoadjuvant chemotherapy, late, it's surgery. First trimester is very tricky because you cannot do surgery, you cannot give neoadjuvant chemotherapy, it's very hard. So in that scenario specifically, that was 11 weeks pregnant, one of the candidates said, I will do mastectomy because I cannot do a local excision, she cannot have radiotherapy, and they cannot give neoadjuvant chemotherapy, it's first trimester, so mastectomy. Then the examiner did not tell him that you're wrong. He told him, that's great, but the patient wants reconstruction. How would you do that? Then the candidate started saying, fine, I will do breast implant. And the examiner asked him, how will you match the other breast when it's a pregnant breast? And also, that's a foreign body you're putting in someone who's pregnant. What is the risk of infection? The candidate said, oh, sorry, I will correct myself. I will do a DF flap. It's an autologous flap from the abdomen. Then the examiner started asking him, do you really want to do a long operation and take the tummy of a pregnant lady? Do you think that's safe? So, and they started arguing, and then the bell rang. And when he walked away from that station, the next candidate asked him, what question did you have? He told him, oh, that was a horrible station. The examiner asked me how to do breast reconstruction in a pregnant lady. That was horrible. That's something we have never come across before. And the following candidates, they all started looking up how to do breast reconstruction in pregnant lady, when actually that was not the right answer. The right answer was, if that lady is 11 weeks pregnant, you can just start to work up, and by the time the lady is ready to have an neoadjuvant chemotherapy, she's past 12 weeks, she is in the second trimester, which tell you a very good lesson. First of all, feel free to say you do not know. Okay, if you think you're going down the rabbit hole with the exam by getting too difficult question, stop before causing any further damage. Do not bluff. The examiners are very experienced. The other lesson to be learned, do not go by the feedbacks from the previous candidates, even during the exam or from previous exams. From previous exams, you will hear things, oh, that we had that scenario that was very hard, and they asked me these very hard questions. They would tell you that the hard question they had, but they wouldn't tell you the answer they answered. And most probably they had difficult questions because their answers were inappropriate. The exam is a stressful condition. It's designed to put you under stress, and they would like to see how do you perform under stress. So please, that's part of it. Okay, this is the level of knowledge required from you. In your specialty, you're required to know everything. Okay, it's ST8. For general surgery, you need to know ST8 level in general and emergency. Emergency is anything with perforation, anything with bleeding. Bleeding anywhere, perforated anywhere is emergency, okay? And with upper GI, you need to know ST6 level, colorectal ST6, and for the rest is ST4. Okay, if you go to the ISP, the curriculum, you will find exactly what topics are covered with ST4, breast, endocrine, and vascular, and transplant. Okay, this is a marking scheme, and that's not a secret. They even send you that sheet once you register for the exam and pay for the exam. So they assess you against these: bedside manner, quality of response, knowledge and judgment overall, and you get mark out of 8. You get, so 4 and 5 are fail, 6, 7, 8 is a pass. Okay. You ideally you should aim for an 8, because if you don't do well in one of the station, and definitely you will have a station that you would not perform as well, unfortunately. So you just want to make that. No one can really tell how the marking is done when they tell you you've got 617 out of 800. How that marking is done, no one really knows. We try to know, but we don't. Okay, these are the common causes of failure: knowledge gaps, you do not know the answer; poor Viva techniques; poor stress management. The commonest cause among these 3 that would result in failure is poor stress management, followed by poor Viva techniques, and the least common cause is actually knowledge gaps. I know, and we have been doing that course for a while. I think that's our 4th year or 5th year, and with 3 diets every year. And the next diet is actually our 13th course. And I came across many candidates that I know they do not have enough knowledge, but they will pass because they've got excellent Viva techniques, bedside manner, eye contact, body language. When I stress them with very hard questions, they do not lose the nerves. So I know that they will pass. And I come across many candidates whom I feel they are very experienced, they've got lots of knowledge. However, they're unlikely to pass just because of those things. The good news is you can handle the 3. Poor stress management, you treat with desensitization. Get used to the stress. Practice more commonly. Practice in front of people judging you. Then you'll get used to the stress. You treat stress by desensitization. Poor Viva techniques, you treat that with continuous practice and feedback. That's why I always say you have to participate in a course, any course. You need someone to give you feedback. You cannot judge yourself. Okay, I'm sure most of you, when you heard me asking the Viva earlier, they thought, oh, I know the answer for that question, that's easy. But actually, once you are sitting in that chair, once you are the one who is being Vivad, you will be surprised how much information you miss. Knowledge gaps is, I think that's the least common reason for failure, because, well, to start with, you already passed part 1. You've got the knowledge, isn't it? And you're all very experienced surgeons, so that's the least likely the cause. Usually it's knowledge gaps in your unfamiliar territories, like you are a colorectal surgeon who has never done transplant and you get a long clinical case for transplant, for example, or for breast. Okay, do you follow so far? You're all very quiet. Just give me a hint that you can hear me. I'm not disconnected. I've not been talking to me over the last 14 minutes. Can you hear me well? Connection is okay. Give me a thumbs up or something.
We're here.
Great. Thanks. So, how to prepare for the exam right now? You've got about 2.5 months or 3 months. First of all, are these enough to prepare for the exam? Yes and no. Yes, they are enough, but you need good commitment. The FRCS exam is very easy to pass, it's very easy to fail. You need to know who you are. You need to know what your problems are, how we're going to tackle them. You need to have a plan. And that's something you find, we try to help you to find in the beginning of the course. We want to help you to find what your problems are. Is it Viva technique or is it knowledge? What are the resources that you need to go to study with? Because believe it or not, some candidates struggle for 6 to 9 months just to find where to study from. That's a problem. You need to assess what you need. You need to familiarize yourself with the unfamiliar territories, like subspecialties you haven't seen before, you haven't practiced before. Identify the easy way that suits you. There is no one size that fits all. I joined one of the courses, I said, and you need to work within a team. Find some of your peers who are sitting for the exam and form study groups. And that's one of the benefits of joining the courses. You're here, you're 15, 20, so just familiarize yourself, see who's gonna willing to join a study group and try to practice together. It doesn't have to be the same subspecialty, by the way. You are practicing techniques, not knowledge. And it's exactly the same for everything, okay? Invest and sacrifice fully. I always say, studying for FRCS is not something you do in your spare time. It's something you spare time to do. The best technique that I found working over the last years of teaching in these courses, do not assume that after a busy day at work, you go home, have your dinner with the family, sit with the children, chat to them about the school, and then after everyone goes to the bed, you spend a half an hour or 45 minutes studying before you go to bed. It will never work. No one has planned that and ever worked, right? The ideal way to do that is to commit every day. After you finish your day at work, if you finish at 5, do not go straight to home. Spend another half an hour or 45 minutes in the hospital library. This is an ideal situation for studying, ideal community, very quiet, okay? Study something for 30 minutes, 45 minutes, and then you can go home knowing that you have done what you need to do for the day. With the Viva question, answering the Viva question, let me again go through that shortly. You can relate to that. You need to understand from the examiner perspective, how do they mark you for the answer? Because the last thing you'd like to do is you think, I have answered very well, but I failed. Or no, I did not answer very well. I'm expecting to fail, but no, I passed. So you need to understand how the examiner mark you for that. In any Viva station and clinical, it starts with an introductory question. Okay, this is a very broad, simple question, giving a presentation about the clinical case, and they go through it with you. And then the second phase is complication decision making, and the third one is high critical thinking and knowledge testing. Introductory question, they give you a presentation as a symptom rather than a condition. They will never tell me what you know about obstructive jaundice or about necrotizing fasciitis. They will tell you you've got someone who's presenting with upper abdominal pain. They will tell you you've got someone who is in day 1 after laparotomy and Hartmann, who's got redness around the stone. Okay, this is not challenging at this stage. The examiner would like to steer you so that you come with a differential diagnosis and say, I suspect this is neck fasc, and then they will pick up from there and start talking to you. So please, please, please do not argue with the examiner. And as a general rule, the examiner is always right. Never argue with the examiner. Okay, the exam is not an educational session. It's not an opportunity for training. Okay, the examiner is not there to teach you. Is not there to support you. The examiner will not assume that you know the information. They will assume that you don't know the information. It's your responsibility to prove that you know the information. He's not working in your favor, I'm afraid. Okay, he's working against you. Okay, so do not try to challenge the examiner at any point. If they try to give you a lead, follow the lead. If he's giving you there is a trauma scenario and you say I will do the ATLS, I will start with airway and I will need to check that there is nothing in the airway. If the examiner say the ABC is done and it's clear, do not go back to it. He's trying to steer you to a specific scenario to save you some time. Don't fight the examiner, especially at the introductory stage. Okay, you just won't like to, we are just trying to know what is the scenario about, because you don't know that yet. You need to follow a scheme, things like ATLS, CRISP protocol, sepsis 6, history examination, if it's a breast triple assessment, just a classification. They test your situational awareness at this stage, and that's something very important. If I'm telling you there's a patient in the ward and the patient is unwell, remember you need to transfer the patient to the HDE. If I'm telling you, registrar is telling you that the patient is in A&E and he's not well, you have to say, I will go myself and see the patient. You need to know, if you need to discuss it with anyone, like we discussed, you need to discuss in the MDT because it's a cancer case. Do you need to involve other teams or not? We are always great in involving teams where in the specialty which is not ours. If you are a colorectal and I'm telling you there is a Burhav, you will involve the upper GI, but you will forget to involve HDU and ITU in a critically unwell patient. So please remember this. Okay. If any scenario starts with your day 1 consultant and that's your first list or first on call, remember to call for help from a senior colleague. That's the first stage done. The good news, it's easy, it's led, and the bad news is if you answer that correctly, you will not get any mark. Please do not expect to pass just because you know the ABCD of the ATLS. The MRCS level can know that. However, you will fail if you don't know that. Okay, so passing that, we go to a diagnosis, and that's when we start asking questions. Okay, you do not pass for just answering the first bit. That's very important. You don't get marks for that. When it comes to complication decision making, that's when the examiner intends to know how will you do exactly as a consultant. Situation awareness is not tested at this stage. It's your management. You have to mention it, but don't make it stop you. So do not keep repeating, I will discuss it at the MDT, or the more I ask you questions about someone with autoesophageal perforation and you're colorectal, do not keep saying, oh, I don't know, I will have to refer to my upper GI colleague. Well, I know that you're not an upper GI surgeon, right? We know that. And the examiner knows your subspecialty. So do not keep repeating that as long as you mentioned it once. Support your answer with evidence as possible, things like NICE guidelines, ESMO guidelines, BSG guidelines, BHS, British Hernia Society, ABS. At the end, if you're asked to consent the patient to break the bad news, you need to quote risks and figures and percentages. Please, 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 when you consent the patient, don't say there are general risks of anesthesia and there are local risks of bleeding and infection. That's very, very lame answer. I want you to quote, if I ask you to consent someone for a hernia repair, I want you to quote for him the risk of strangulation per year. I want to quote him for the risk of persistent pain after, the risk of recurrence, all that. Avoid medical jargon. Things like ischemia is a medical jargon. Endoscopy is a medical jargon. Okay, esophagus is a medical jargon. Okay, it's called gullet or food pipe. And from seeing previous feedbacks from previous candidates, you fail for these. Okay, if you mention medical jargon, you lose marks. Okay, the other thing, you need to discuss alternative treatments, consequences of not accepting the treatment. You will always find something like, oh, the patient say, no, I don't want to have your treatment. And you need to be able to explain to the patient why you think this treatment is better, not try to force him to have the treatment. After you've passed that, you will get then asked about trials, high guidelines, what is the high niche treatment, what are the future prospects, what if there's an unexpected complication. When we discuss the splenectomy, what do you do if there is persistent low platelet count, as we discussed, what there is a persistent output from the drain. If you get asked these questions, congratulations, that means you passed these stations. You just put in the train at the top, you're just getting the full mark. Okay, and that's why I say trials, they're not going to fail you the exam. They're going to help you to get the full marks. Okay, but you're not going to fail just from not knowing these. Okay, any questions about this so far? Okay, great. So very briefly, let me go about our course. So, as I always say, I understand that what we offer might not be the cheapest course around, but we know that it is the best value for what you get. Because that's something that I've been curated. We did not start it like this. We started as a group of surgeons who are recent pass outs. With everyone, we started as just a group of 6 to 7 faculties. Now we're more than 25. It's a full mentorship program. With everything probably that we think you will need for the exam, starting with offering resources and schedule, lectures, and intense Viva, and then the cherry on the top is a mock test. Okay, how it works? It goes over the period of 3 months. It will start next weekend, next Saturday, this Saturday actually. Okay, we will have a topic for every week. What happens? You get lecture or 2 during the week. Okay, usually they are the evenings of Tuesday and Thursday, something like this. There are some topics that you will have 1 lecture for. There are some topics you will have 2 lecture for. I'm guilty for breast. I give about 2 lectures. Everyone is about 5 hours long because I would like to assume that you know nothing about breast at all. Okay, so I start from basics and build it up, giving you all the information you need to the exam. So you will get these 2 lectures, and then over the weekend, you will have 2 Viva sessions, one on Saturday and one Sunday. If it's general surgery, you would go into groups because we would like to make sure that there are small groups and everyone has got the opportunity to participate. If it's something specialty, something like colorectal or upper GI, we'll split you into 2 groups. The specialty group will have their intense ST8 level questions, and the others, the general trainees, will have the ST4 or ST6 level knowledge vivas. Okay. You get to participate, and what I find useful as well, you learn by watching how others answer the question. Okay, and what feedback they will get. And at the end, you will get personalized feedback sent to you at the end of that weekend. And then we'll go on and on. There is a schedule over 3 months. There is LMS, we call it the Library Medical System. It's like an app that you can access on a single device. In the app, you will find all the resources, all the trials that you need to know about. We update them regularly. It's not like pile of stuff that you go through. These are very carefully selected and updated regularly. And you will find all the recordings for all the sessions, lectures, vivas, everything there. But so there are some restrictions with the LMS. We'll come to this later. It sounds great. There are a few things. Do not expect this to happen. Spoon feeding of knowledge. We cannot tell you everything you know. Do not come and say, oh, we got that in the exam, but that has not been discussed during the course. Okay? We can't cover everything in surgery in 3 months. That would be unrealistic. Okay? False reassurance, do not expect that as well. We will not tell you that everything is good, just try to do some more work and everything will be fine. We will be very blunt with you. And actually, we do that frequently. If we think that most likely, if you sit for the exam, you will not pass, we will be blunt with you. We'll tell you, look, based on your performance so far, you will unlikely pass this attempt. If you'd like to give it a go anyway, be our guest. But if this is very precious for you, you might want to postpone it and sit for the next time. We do that. Okay? Some people like that approach, some people don't like it, but I think we've got a duty of being honest. And do not expect that we'll cover everything as well. Okay? How to get most out of this course? Okay? You do not want to make a schedule for you for all the topics to study for the FRCS. We have done that for you over the period of 3 months. You just need to commit to it. Okay? We found that the more you participate, okay, the better you benefit from it. We found that candidates who did not sit regularly, they are the ones who most likely failed. We do not have very high failure rate. We'll go through that shortly. But those who did not pass, they have not been consistent with attendance. We understand that being committed every weekend is almost impossible because you have got on calls, but you have to try your best. And what I say, never miss your subspecialty weekend. Swap it. That's very important. Sincere efforts from day one, as I said before, it's something you spare time to do. Do not do it in your spare time. Disciplined preparation. So you've got the knowledge, you've got the lectures, you've got the resources. What you need to do is to prepare. During the week, we have a chat group. It's not that WhatsApp group. There is a special Telegram group. Okay, we kickstart that once you join, and during the week we post scenarios on that by the faculties. And based on the answers, we give you constant feedback. You will find 2 or 3 scenarios every day, things that you can go through in between cases in theater, during lunchtime, lunch break in the hospital. And also, you can post your own questions, any difficult scenarios, or that was a previous exam question, how to answer that properly. And we try our best. We do not claim to be the best surgeons who know everything, but we try to help you to answer the questions to help you to pass the exam, because this is our best goal here. We don't try to teach you surgery. We try to help you to pass the exam. Form study groups. From the course, you will know who's who. You will get to meet your colleagues. You get to meet colleagues who is in your own subspecialty. Benefit from that. connect with each other, form your private study groups, be consistent with that. That will help you. Speak to mentors to your need. We're all approachable about everything. If you got any question about anything, if you're not sure whether to pass to sit for the exam or not, feel free to speak to us. We are always all of us are happy to be contacted. If any of you has not passed in the previous attempt, is not the first attempt, and they've got feedback, we are very happy to go through that feedback with them and form a plan. Okay. You can review your own videos and see how to correct and learn from others. I see it as very important as well, as I said. Blunt feedback, this is what we do. I'm afraid we give you grading with against. You will get monthly reports based on your performance, the extensive Viva training. By the time you finish this course, you will have more than 100 hours of Viva. You wouldn't get that anywhere else. That's why I say the best value. Small groups. There is one-to-one mentorship that's not included in the course. This is an extra for those who need that. If at the end, after the mock, you think, well, I think I'm weak in that spot and I would like to do more extensive one-to-one with that faculty member, a mentor, that's something you can book and we can accommodate based on what exactly you want us to help you with. Most people don't need that at all, okay? But if you need it, it's that. There is IT support. They are available, I would like to say 24/7. If you've got any problems with LMS, with the access, you can always chat to them and they're always happy to help. Okay, this is how we mark you up. And this is the monthly report that you will get based on your performance and and how will you proceed, okay? And you always have the opportunity to discuss it with any of the mentors, okay? With the mock, that's how we mark you. This mimics the same feedback and the markup from the actual answer sheet. Our mock exams are very vigorous. We know that. They are very extensive. What we'd like to think is, if in the mock you had a scenario and I give you 6 out of 8, that means no one would ever give you less than that for your answer. Some might give you more. Like when hello. When one of the candidates was asking, did I pass or fail? I would say, well, I would give you 5, okay? But you might get more in the exam. The constant feedback that we hear and that we would love to hear, that actually the mock test was harder than the actual exam. Our course is accredited by the Royal College of Surgeons of Edinburgh. I think that's the only one, and you will get a CPD certificate for that. That's based on your participation, not based on your subscription. So the IIT, they have to calculate how many hours have you participated, and we give you this exact hours based on your participation. Some candidates reported that they could claim the fees of the course from the study leave budget. We are happy to support you with that, but every hospital has got its own policy. This is an example of the schedule. The updated schedule is in the WhatsApp group if you'd like to go through that. We will publish that 3 months ahead so you know exactly when would be your session. And please, 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 if you need to do any swaps, do it now. Okay, so that to get the best of it. Okay, we cover everything. We even, when it comes to the lecture, we cover things like radiology for the FRCS. We've got two lectures for that. And topics like endocrine surgery. And we pride ourselves with our pass rate. This is one of the 7th actually course. That was 6 courses before, and that was cumulatively higher than the national average, especially for non-UK trainee. This is a cumulative average of pass rate for non-UK trainees after 4 attempts. But actually, the pass rate for non-UK trainees with the first attempt is something around 23% or 30%. The figures are published on the GCIE website. Okay. This is an example of our mock schedule, how the mock Viva would look like. We try to mimic the actual exam conditions with 1 long, 2 short case for general surgery, trauma, critical care, academic, paper and basic science, and specialty surgery. And that's how the mock schedule would look like in our course. It's very intense over the period of 2 weeks, to mimic the similar stress that you get during the exam. This is the number of hours taught. That's the sample. That was actually on the 8th course. I think that number steadily increases rather than decreases. You have 94 hours of mock Viva. The lectures are about 60 hours, and cumulatively you get something around 130 hours at least. And that's why I say that's a good value. I know it's a long commitment. It's not for everyone, but for those who would be able to follow I think that would be the best for them. This is the Telegram group. This is how it looks like. It is subdivided into islands like this, based on subspecialty. We publish questions every day, and we get answers as well. And then I think we consistently, when we go through this at the end of the course, we find that at least 3 or 4 questions in the exam are just from the Telegram discussions. The LMS, the application, the thing that you can only access it from a single device at a time. So the app is available in the App Store and the Google Play. I think now there is a macOS app and the Windows app as well, but you cannot take screenshots. Once you take a screenshot, that has to be reported to the admin, and if it happens twice, they might restrict the access. You cannot download any videos or record the screen, and you cannot access it from 2 devices at the same time. If you'd like to change the access, you contact the IT team and they can do that for you. For example, if you're studying from your laptop or from your iPad, but you think you've got a long commute, you'd like to listen to the lecture that you missed, and you like to do that on your phone, you can contact the IT team and they can give you access, change the access to the phone rather than the iPad. Yes, Gamal.
So I'm actually subscribed to the course, and just a question about that. So can I log out of the application on my computer and then use it on my login on my phone, or do I have
No. The Mac ID of the device is stored in the IT team. They have to do that for you. They have to do that for you. They have to log you off the thing. So if you're logged in the iPad and you'd like to log on your phone, for example, once you log out of the iPad, if you try to log in the iPhone, they will sense that you're actually logged in the iPad. They have to reset all the clients, and then you get an access to the client on the iPhone. I know it's a pain, but it's done for a reason. But on the other hand, I claim that the IT, you will always 24/7 find someone who will answer your question. They usually solve that within 2 hours in maximum.
Can I know how we get how do we contact the IT team?
There is always WhatsApp group. Okay, if you subscribed already, you will find a few WhatsApp group. There is one dedicated just for IT and admin issues. Okay, once you post a query there, someone will always pick that up and contact you immediately. If you're in the WhatsApp group, I can signpost you to that one, Gamal.
Thank you so much.
Welcome. And that's it. Anyone has got any question about anything? Yes, Ashraf. Ashraf, you're muted, I think.
Yes, sorry for that. Yes, I want to ask, exam will be for international GCF, and it will be in the November. The course will end in the end of August. If I need to review the material to listen to some mock recordings,
you will continue to have access. You will continue to have, everyone will continue to have access to the LMS till the results.
Yes.
Of your exam. Till the results of your exam. Don't worry about that. Any other questions? Good. I wish you all the best. And if you are starting with us next week, then I think next week would be the general surgery. We're going to kickstart that gently. It will take you a while to get to the base. Okay. Don't be intimidated if you feel that you know nothing next week. Okay. The common feedback we get from the candidates is you notice an improvement after a month or so, but the key here is consistency. Okay. Can you do it in 2.5 months? Absolutely, you can do it. but you just need to commit. Okay.
Sorry,
Anyone has got any question? Sure, Gamal. Sorry. Yeah, of course.
Sorry. I can see on the first day, which is the 13th, the 13th and the 14th, we have general surgery vivas.
Yes.
So how would that go? Because I think this is for everyone.
So what will happen? You will have access to PrepMedico Hub, okay, which is a website. You go there, you will be allocated to one of the groups. So if you, I think I'm not sure what's the number of registration for this course. Usually we cap the number at very low. We get oversubscribed for 2 or 3. So I think we stop it at 30 or 35, but then we just get observers. Anyway, you will find yourself allocated to a group of not more than 10 or 12 candidates with a faculty. Once you log into the PrepMedico Hub, everything will be through the WhatsApp. One of the admins will tell you, you need to go there, register for the PrepMedico Hub. You go there for the day, in the morning. You'll find that you've been allocated, for example, to the red group, and this is the link to join. Okay? Once you join the link, then you will find yourself with one of the faculty members, okay, with other colleagues. And what will happen, they will start giving you some presentations if they need to, and then they will have to go through all the candidates with you. You do not get not to participate, guys. You have to participate, and you have to turn on the cameras. And that's for your own benefit, not for ours, because when we give you feedback, it's not just about the quality of answer. It's not about the content of your answer. It's about your quality. It's about your body language. It's about your eye contact with the exam, all that. And we cannot assist that if your camera is turned off. So yes, once we go through all that, and it's about 3 hours or 4 hours, and at the end, you will get a feedback. Did I answer your question, or did I get it,
yes,
Gamal?
Yes, I did have a follow-up. So the Viva, let's say it's for about 3.5 hours.
Yes.
So each one of the participants will get like one Viva to go through.
Depends. No, at least you get 2 Vivas during these 3 hours.
Okay.
At least. Okay. If not more.
Sure.
Okay. And that's something we pay attention for. We would like you to participate, not just to watch. Okay. Although you learn from both, you learn from participation and from watching, but you did not pay all that just to watch. We know that.
Sure thing. Thank you.
Okay. Brilliant. If you've got no further questions, we'll see you all next week. And if you've got any questions in the interim, feel free to use our WhatsApp group. If you've got any questions, you don't want to post it in public, feel free to text me directly. I'm very happy. I'm on the group. Or text Manny directly, Mr. Catherville, Manny Camden Catherville. He's the course director. He's always very responsive. I always joke with him. I tell him, I don't think that you are a real person, Manny, because believe it or not, I've never met him in person. I tell him, I think you're just an AI, like Manny GPT or something like this. Okay. Best of luck, and I wish you the best in your preparation journey, and wish you all success in your exam. Thank you very much.
Thank you so much. Thank you.
Thank you.
Thank you.